So as we've already said, the point of a meta-analysis is we have all these studies. They've each estimated the effectiveness of this intervention, depending on our question, compared to whatever we've decided it's important to compare it to. And we can measure the size and consistency of that across more than one study. That gives us power, and it should give us precision if we do it well. Okay? So we're not going to reject something that actually works. We're not going to be fooled by unrepresentative, falsely positive data, but quality is important.
Might not be screen sharing. Let me check. What do you see, Sandy? Yeah. Hold on. Sorry. So this is what we want to screen share. No, that should be it. Nope. I think we were sharing the wrong one. This is a whole bunch of stuff now. Okay, still recording?
Still recording.
Okay,
Now it's recording.
start over.
Happy day. Well, those last few slides were just repeating what I'd already told you. So, so how does it work? Well, in a meta-analysis, we'll take and estimate the effect size for each study. We'll just take their data and get the point estimate of the mean difference between groups and the 95% confidence intervals for that point estimate. And then we'll put them all together to try and get to some sort of grand mean. But we don't weight all the studies equally. Most meta-analysis approaches will weight a study directly on its precision. And of course, precision reflects the size of the study, yeah? So bigger studies, smaller standard deviation, smaller standard error, so more precise, okay? So bigger, more precise studies add more weight to the pooled estimate, and smaller, less precise studies add less weight. Done properly, that should be more precise. So this is a forest plot here, and you'll all have seen these. And I'm going to try and convince you that they're beautiful and very, very, very easy to interpret. And just to reiterate something I've said about 100,000 times, size matters. We're always interested in that size and precision of the effect estimate, much less so than that p-value. The information you need when you look at a meta-analysis is, what's the outcome measure? What is this effect size reflected on? So what's the scale? What are the units? Are they valid? Do they represent something we're interested in? Have they used any cutoffs? Is this one of these continuous scales that's been dichotomized? So you could have a meta-analysis of responder analyses of pain. So it might be the proportion of people who experienced a 50% improvement in their pain, using the impact definition, for instance. Is there an effect actually there? So that's, when you look at the pooled estimate of effect that you get, does it cross the line of no effect? And if so, how far? Which of course is just really a corollary of the p-value. How precise is the estimate in terms of those confidence intervals, and how big is the effect? So here's a forest plot. Yeah.
So is kind of like the quality of the studies that go into the meta-analysis just based on their size?
No, so the weighting is based on size. You can look at the influence of quality within a meta-analysis, but a standard meta-analysis doesn't weight on quality, it weights on precision. Okay. But we could talk about what we might do about quality when we get into it. Okay. So this is a forest plot, and as I say, they're really easy to understand, right? First of all, we've got the important line in the middle, which is 0 in this instance, but if it was a dichotomous outcome, and we were looking at risk ratio, what would the line of no effect be? It wouldn't be 0, it would be 1. Cool, okay? And then we have our horizontal axes, which is our score on whichever outcome measure we want. So in this instance, it's a pain visual analog score. So if we're moving this way into the minuses, less pain is good, okay? So that favors the treatment over the placebo in this instance. And if we're moving in this way, i.e. that actually pain scores were higher in the treatment group than they were the placebo group, that favors the placebo. Does that make sense? So what we have for each study then is a blob. These are the green blobs, right? And that's the point estimate of the study. So that is the mean, usually it's the average between group difference, right? And you'll notice that the blobs are different sizes. Why are the blobs different sizes? So this blob's pretty big relatively. This blob's teeny tiny. It's the amount of weight that, yeah, it's the size, it's the weight that it's contributed to the overall effect estimate. And you'll notice that big blobs are associated with narrow confidence intervals, yeah? And small blobs have quite broad confidence intervals because size, precision, make sense? So then what we can see here already, right? We've systematically reviewed the literature. Let's not even worry about pooling it at the moment. We can just have a look and see what each individual trial found. Very simply. Did this trial find a convincing, statistically significant reduction in pain compared to placebo? No. Why? Exactly, crosses the line of no effect. What about this one? Well, it did, didn't it? It would be statistically significant. I mean, whether it's clinically meaningful is quite another question, but it's statistically significant, right? And then what we do then is we end up with this diamond at the bottom, and that's our estimate of the pooled effect size. So the center of the diamond would reflect the average, and the horizontal points of the diamond reflect the ends of the confidence intervals, 95% confidence intervals usually, yeah? And it takes into account the weighting. So the smaller, more precise studies have contributed more to that overall effect. And so in this instance, we see it's probably a statistically significant effect because the edge of the diamond doesn't cross the line of no effect, right? But this is actually a visual analog scale. So that would be, in the middle there would be a 1-point reduction on average in pain. This looks like about a 0.3, 0.4 point reduction on a visual analog scale, which is kind of looking pretty trivial. It's looking very small if we're interested in pain. So the components of a forest plot we've already talked about. This one is from an intervention for COPD, an educational intervention to stop people being readmitted to hospital. So it's a hospital at home intervention. You go in, you treat them in the community, give them some education and support compared to usual care for preventing hospital readmission. And so our outcome is dichotomous. You're readmitted or you're not, right? So it's counts. So if we have a look here then, we can see the data from each individual study. So this is a tiny study, right? We've only got 25 people in the study. And in the intervention group, 6 were readmitted. In the usual care group, 2 out of 12 were readmitted. And you can see that expressed as an effect estimate, very wide confidence intervals because it's a small study, cross the line of no effect substantially. Are any of these studies looking like they might be statistically significant? No, right? So even the bigger ones, although even the bigger ones aren't massive studies, it's worth noting. So there's so much information here as a user that you can just get. You know exactly what the point estimate and precision of every individual trial was, which is actually interesting. Right? And you can have a look visually at the forest plot and see how consistent they look, how much they overlap in terms of confidence intervals, right? And then of course at the bottom, you're going to get your pooled effect. So here we've got the differences between treatment and control expressed graphically and numerically. And here's the weight that each study contributed to the overall pooled effect, right? So this tiny study contributed almost the square root of nothing, right? And this is the biggest study on the block and basically contributes about a quarter of the weight to that pooled estimate. Everyone happy? Isn't it easier to make your way around? I think they're lovely. And then we end up with our pooled effect expressed graphically as a black diamond. So in this instance, do we have a statistically significant reduction in hospital readmission associated with our intervention? No. There's an 11% reduction, but our true population estimate could be anywhere between go on, you know it, be bold. Go on.
Why is everyone looking at me?
So our point estimate is an 11% reduction in the risk of readmission, but the population estimate could be anywhere, the true population value could be anywhere between, if that's 11, come on, you're killing me here. 28, percent decrease to a 12% increase, right? Woo. Okay, and here's something really important. check the labeling of the graph, because depending on the analysis used and the package and the way it's been set up, it isn't always that moving to the left is a good result. You need to know what the axes are. And people often make that mistake. They eyeball it, but they don't look at the scale. So the true answer, depending on the quality of these included studies, is that the hospital at home could lead to anything between a 28% reduction and a 12% increase. That would often be interpreted as no statistically significant difference in the likelihood of hospital admission 2 to 3 months between the two interventions. Here's another example. Mudgil et al. In Thorax from 2000, which is a study of a self-management program for the cheap, short, brief self-management programs for preventing readmission, emergency admission to hospital with asthma, which is, of course, actually a serious and clinically very important event. Right? So we've got adults with asthma. The intervention group get this individual education program. The control group get routine follow-up, usual care, no specific intervention. So these are the data from Mudgil. Not a tiny study, right? I mean, almost 600 people in the study. Did it find a statistically significant result? No. Is the point estimate going in the right direction? Yeah. So the point estimate is a 47% decrease, but there's loads of uncertainty around that estimate, right? Okay. One of the reasons there's so much uncertainty around the estimate, even though the sample size is big, is because there's a very low event rate. Right? So we're dealing with very low numbers of events. You're actually going to need really big trials or lots of reasonable sized trials all put together to show a benefit, if indeed there is one. Right? So P equals more than 0.05. Let's not do it. Let's give up, man. We've done our trial. We've got our answer in your face. Very depressing. Or we can systematically review all of the relevant studies and put them in to a meta-analysis. So that's what a meta-analysis is. It's group hugs for data. Right? We're bringing it all together. So if we have a look down here now, we've got a huge number of studies. Do any of them show a statistically significant effect? No, and the key reason for that is these low numbers of events. Happily, most adults with asthma aren't getting regularly readmitted to hospital. Right? But when we pull them all together, look at the pooled effect size. So what's the relative risk reduced by? Do it. 36%. And the true population value could be somewhere between 50% and 18%. But is that statistically significant? With a p-value for that comparison, because p equals less than 0.003. Do these studies look reasonably consistent, do you think? Lots of overlap, right, between them. One sits in a funny place, but they don't look so inconsistent. We can look at that, though, and we can quantify how consistent they are statistically. So if you look down here, we've got the test for heterogeneity. Right? And the test for heterogeneity is basically quantifying how much variance between the effect sizes in these studies can't be explained by chance alone. That's the Cochrane definition, anyway. Okay, so how much of this variance is worrying might represent something other than chance. So we do a couple of tests normally. The chi-square test tells us whether the heterogeneity between studies is statistically significant, normally using the traditional threshold of 0.05, although some studies are a bit more, they use 0.1. And then we can quantify to some extent, estimate to some extent, how much of that variability can't be explained by chance alone. And that's what we get from the I2 statistic. And in this instance, it's 0%. So the p-value for heterogeneity is 0.7. And the I2 statistic is really low. And what that's telling us is, actually, these studies don't vary a great deal in their effect estimates. The effect estimate is consistent, which strengthens our belief that it's legit, right? Where you get lots of heterogeneity, statistically significant heterogeneity, and a very high I-squared, well, that's cause for concern that these studies aren't all estimating the same true effect size. Does that make sense? So that's awesome. So we got all the studies together. We got a clearly statistically significant, much more precise result. And we then have to look, we want to look at the risk difference here and say, well, what's the number needed to treat? And of course, you guys could probably derive that. But the bottom line is, we've got a statistically significant event. The next question then is it worth doing? Is it worth offering this to make a clinical difference? Hospital readmission, of course, is an important outcome. And the intervention is quite cheap and easy probably to scale up. So something that you would consider. Okay. This is the Cochrane logo, the new one, same as the old one, but nicer colors. And what's that in the middle of it? It's a forest plot, right? But it's not just a picture of a forest plot. It's an actual forest plot of perinatal steroids for preventing respiratory distress in premature children. And the whole point was, over the years, there had been a few trials on whether if you deliver dexamethasone to people who are going to deliver early, whether that will reduce respiratory distress, which of course is a major killer of premature babies. And the results seemed a bit conflicting and there wasn't any consensus. And then they did the systematic review and found actually the evidence is reasonably clear and consistent that this is a good thing to do in this group of people. So that's why that was taken as a kind of poster child for the process, because that's another example, just like the ones we showed at the start, of how when you aggregate the data in a really systematic and meaningful way, you save lives. You know, you can make much better decisions. The problem with a meta-analysis is asking the question, when is it reasonable to do it? Because you'll never find two trials that are the same, that ask the same question, with exactly the same intervention, delivered in the same way, to the same group of people for the same duration, using the same outcomes at the same time point. It just doesn't happen. Well, it doesn't happen often. I mean, you might have occasional direct replication studies, but actually science is really bad at direct replication because it's not rewarded culturally, really, in an appropriate way. So we need to ask ourselves before we see the data, well, when would it be appropriate to pool studies? So let's take core stability versus, I don't know, usual care as an example. And this comes back to what we did the other day. What's core stability? When are different core stability interventions core stability-ish enough that it's reasonable to say, well, they're really estimating essentially the same thing? When are the chronic back pain patients similar enough that we think they're estimating the same thing? Actually, that's easier these days because since 85% of people can be diagnosed with chronic non-specific low back pain, and most trials are done in that population, you know, and we have reasonably consistently applied criteria for chronicity and non-chronicity, that's not so bad. What was it compared to? So I'm interested in core stability versus usual care. Well, what was usual care? Because if one lot of usual care is off you go, maybe see your GP if you're still having problems. And the other one is come in and we're going to give you best practice as ascertained by a German guideline from 1964, which is 6 sessions of electrotherapy and whatever else. Then these are different things, okay? Which time point should we take? Immediately post-intervention? Up to a week post-intervention? All of these things are not statistical judgments. In fact, very few things when you're designing a protocol are statistical judgments. They're about what is reasonable to assume and what represents a level of difference that really means we're trying to put chalk and cheese together here. And Steve and I were talking about this at lunch. I'm a bit of a lumper. You can divide researchers into whether they're lumpers and they're actually quite insensitive to issues of heterogeneity. They want to get the data, get it together and have a beautiful forest plot and get an outcome. And then you've got the splitters who are so worried about every source of variation that they think every study is a subgroup of one, or even every patient is a subgroup of one if you go to one conference. Yeah. And that's the hard part. And there's no answer to that. It's a judgment. It's a nuanced judgment. But the decisions that the researchers make in planning their analysis affect what conclusions you can draw from the evidence. Good researchers will be very clear about that. You might have to make your own judgments about that if they're not, or you don't agree with them. So it's not always appropriate to pull data, okay? So the great line is you don't compare apples with oranges. Unless, of course, you're just asking a question about fruit, right? In which case, maybe you would. That makes sense? Cool. So we've touched on this already. When we're doing a meta-analysis, we look at the presence of heterogeneity using the chi-squared to tell us whether it's statistically significant, and the I-squared as an estimate of the quantity of that heterogeneity. Once it's significant, it starts getting up above, I mean, there's no accepted threshold, but up above 50, you know, you're starting to get 50%, you're starting to get concerned about it, for sure. But the problem in complex interventions is if you're doing a systematic review of drugs, often it's the same molecule, often at an accepted dose. There's much less heterogeneity, but still some in terms of heterogeneity of the population of the trials. When we're doing physio interventions, wow, man, I mean, those things really differ. And that's the challenge of using these tools for these types of interventions, okay? Where you have significant heterogeneity, you need to be cautious. Of course, you can investigate it and you can explore it, because it might be that you think it's reasonable to pull these studies together, but there are some reasons we would predict that people might differ, or the effect size might differ by some characteristics of the PICO criteria, okay? So what you can do in your protocol is decide which the important ones are and operationalize a way to explore heterogeneity by those characteristics. So you might say, if we're doing chronic pain, that I think my intervention will work differentially for people with central neuropathic pain compared to people with peripheral neuropathic pain compared to people with non-neuropathic pain. That's really low fidelity, but it's an example of what you might do, right? And then you can, if you've planned that, then you can have a look at, well, if you subgroup the studies into those, does heterogeneity decrease? And then after that, does it change the effect size? There are other tools that you can use, like meta-regression, which essentially performs a regression looking at how that variable that you think might modify the effect size, whether that does actually associate with the size of effect as well. And the other thing that most good reviews will do is test the assumptions of the analytical choices that they make. But we'll come on to that a bit more in a minute. Here's an example from the repetitive transcranial magnetic stimulation world, where we get all the studies of RTMS, which is an electrical brain stimulation technique in chronic pain, and we lump them all together. And when we lump them all together, we get an effect size of a standardized mean difference of 0.32. So a small effect by Cohen's rules of thumb. And our confidence intervals are somewhere between 0.51 to 0.13, but heterogeneity is high. And you don't even need that to know that heterogeneity is high. Look at how these are wobbling around. Right? I mean, in this area particularly, these studies are very inconsistent. Right? There's a lot of noise in that sample. Of course, why would I lump all transcranial magnetic stimulation together? So these are studies that stimulate different parts of the brain. They use different stimulation parameters. We know that high frequency stimulation increases excitability, and low frequency stimulation is inhibitory, has an inhibitory effect. So these are competing mechanisms. So there's another potential source of subgroups, okay? When we have a look, look at the low frequency subgroup. Actually, there's no heterogeneity here. The I2 for this group is 0. And actually, we've got a non-significant effect that's erring towards favoring sham in that group, which probably means that nothing's happening, but could mean that it's increasing pain. So low frequency stimulation, there's low heterogeneity in that subgroup. So subgrouping by that has resolved that heterogeneity for that subgroup, but we don't see an effect that we're interested in. Right? When we then look at high frequency studies, we don't resolve any of our heterogeneity because all the heterogeneity is in this group, you can see, yeah? But we do see a statistically significant effect in that group. So we're still really uncertain about that statistically significant effect because we've got this unresolved heterogeneity, despite subgrouping by stimulation parameters. Yeah? If we have a look, because still in that group, we've got studies that stimulated the dorsolateral prefrontal cortex, studies that stimulated the premotor cortex, studies that stimulated the supplementary motor cortex, etc. And of course, you know, the brain stimulators wouldn't hypothesize necessarily that you're going to get the same result across different brain regions. So if we have a look at a subgroup of most studies stimulate the motor cortex for pain. And when we have a look at a subgroup looking at the motor cortex, we see a slightly larger standardized mean difference and much less heterogeneity, right? But we're really stretching our analysis credibility now because this is like a subgroup of a subgroup. Right? And so it's important that whatever we do, we plan to do, and we hypothesize that we do. But we don't consider this to be the same level of data as that overall analysis, which really had the benefits of randomization. Because we've stratified this to a point now where all we can do is say it's exploratory and interesting, but it's certainly not conclusive.
But if you started with that question,
if we started with that question, it would be fine. Absolutely. What's really interesting, though, is if you do a single dose of repetitive TMS, you get a small effect on pain. It's not clinically important, but you get a small effect on pain. When you look at studies that have delivered multiple doses, this is old data, we've now got about 7 or 8 studies, some of them are a bit bigger. The data are all over the place, even when it's high frequency stimulation of the motor cortex. So you've got an interesting phenomenological finding from the lab, but all our studies that represent more how the tool might be used clinically aren't coming up with a compelling argument for TMS. It's very inconsistent and uncertain. When we're doing any kind of analysis, we have to decide what statistical approach we're going to use, what model we're going to use, and all models make assumptions, right? So you guys know that if you're going to do a t-test, that's a parametric test. One of the assumptions that we make is that the data are normally distributed, yeah? Well, it's the same thing when we're picking our meta-analysis model, and you don't need to get too deep in that. There are 2 key types of model. There's a fixed effects model and a random effects model. And which one you choose depends on really the question that you're answering. A fixed effects model assumes that across all these studies, there is one truth. There is one true effect. And all of these studies with some element of error and bias are trying to estimate that one true effect. Think about that. If we have 4 or 5 studies of the same drug in the same group at the same dose for the same period of time, that would be pretty reasonable, right? Think about that with 5 different trials of core stability for back pain. Does that sound reasonable now? Where the details of the intervention change, the fidelity within which it was delivered change, the types of people might change, the dose might change. And so at that instance, we want a model that doesn't make that assumption that there's one true effect. And a random effects model assumes that studies are estimating a distribution of similar effects. That's hard to make sense of, so let's look at it in a diagram. The fixed effects model holds that there's one truth. There is one effect size, okay? And that's signified by the red line. And each of our studies estimates that truth with a degree of error, right? And that's the assumption that we're making. A random effects model suggests that each of these studies is estimating its own truth that's true for that intervention under those circumstances. But because these interventions are all similar, that those truths will distribute around a kind of average truth, right? So there isn't one true effect size because each of these interventions is a bit different or done in a different group. So each of our interventions is estimating a slightly different effect size. So this study is estimating that effect size, this study, that effect size. But we can get a grand average of those to get a sense of how valuable is core stability within that heterogeneity. Generally speaking, in most circumstances, a fixed effects model is less conservative. It's more likely to give you a positive result with a big effect size than a random effects model. So in physio interventions, we would generally err towards a random effects model being the careful, cautious choice of model. But you at least need to know what the model was. They need to report that, okay? You'll often see studies using a fixed effects model, not for any really good theoretical reason, but because it made the effect look bigger and more consistent, okay? So when we're planning a meta-analysis, we need to ask ourselves, and again, it's really important that most of these questions have nothing to do with statistics. We ask ourselves, what is the comparison of interest first? Which model is most appropriate? But importantly, what are the important effect modifiers? Are there important subgroups to explore and consider? Is it reasonable for us to put all these together, or is it just making such wild assumptions that we're going to get an effect estimate? It won't mean anything. It won't be meaningful. Let me come on to publication bias. We've talked about that already, right? So that's this propensity for negative studies not to make it to publication. And that's much more common in negative small studies, partly because negative small studies are easier to not make noise about and hide. Okay. The other reason may be that small studies are often a little bit looser in their methods and have more risks of bias. Or a less nihilistic view is that small studies are able to deliver an intervention with greater fidelity and more precision. So there's lots of things that might contribute to that. We don't have a really great way of looking for publication bias, but we have some indicators of possible publication bias. And they're not directly measuring publication bias. They're measuring small study effects. They're measuring whether the size of the study alters the effect estimate. So we talked about this yesterday, didn't we? This is a funnel plot. And in an ideal world, big, precise studies will sit very close to or on the line of our pooled effect size. And smaller the studies get, the less precise they are, the more they'll spread out either side of the pooled effect size. But they'll spread out evenly either side. Where we've got publication bias, we might see quite a few small positive studies, but nothing going on in the small negative studies. And that's a sign that small negative studies may not be making it to publication. But it isn't prima facie evidence of publication bias. We need to be careful how we report it. Here's an example from brain stimulation, RTMS. So you see that we've got this small pooled effect size, and we've got our studies, our bigger studies, and none of them are very big, clustering close to the effect size either side. But as the studies get smaller and less precise, this poor lonely bugger sits all on his own on the wrong side of the effect size. Now, actually, this isn't statistically significant. And the reason it isn't is because there isn't enough variance in the size of the studies because all the studies are kind of small. Okay? But here's my favorite funnel plot I think I've ever seen. And this is from a recent systematic review of glucosamine supplements for osteoarthritis. And what you're looking at here are all the trials of glucosamine versus placebo. The red ones are lots of different manufacturers, and the black ones are all from the same manufacturer, trials of a product made by one manufacturer. What do you see? Yeah, well, yeah, maybe. But what's interesting here is, first of all, we have a tiny standardized mean difference. It's tiny, right? And that's including all of these studies. It's teeny tiny. And then we have this strange situation where studies of this Rotterdam-Madhouse glucosamine product really skew in one direction. They're not spreading out as they get less precise. They're going in very much one direction. Now, what was weird was the conclusion in the abstract was most of the observed heterogeneity in our meta-analysis is explained by brand. Well, you can see that, right? These guys stand alone. And trials using the Rotterdam-Madhouse glucosamine product had a superior outcome on pain in OA compared to other preparations. Fine, they did. But there's something else we should say about that. And that is that this data set appears to be affected by substantial small study bias. And that's going to have an effect on the estimate. Actually, if you removed all these, how much of an effect do you think you'd have for glucosamine? Nothing. And I just think it's a really good example of what funnel plots can show us. They can't show us that there are lots of hidden negative trials, but they can give us a hint that something is awry there. Okay. This is just another example of the importance of looking for unpublished studies. This is, I think, what is it? Reboxetine? Yeah, reboxetine, the antidepressant for depression. And you can do a meta-analysis based on the published trials, or as these guys who work with Cochrane did, go and spend ages lobbying regulators for all the data. And so if we have a look, these are the data at the top for remission of depression. These are the published data. A fantastic effect size for reboxetine. One trial, 6 unpublished trials at the time they did this review. And that's what you get from them. Very different, right? And then the pooled effect, there's nothing there really to see. But it gets, you see the same picture for response, treatment response. I don't know quite how they defined that. But this is even worse, right? Adverse events in the published data, very, very uncertain. Get all the data together, and there's very little uncertainty that the reboxetine is associated with adverse events. And when you look at the list of adverse events, some of them are really important. Stuff like emotional lability, suicidal ideation, like impotence, life-affecting things. And you see the same picture lower down. And this is about industry not giving us all of the picture, okay, getting a selective view of the picture. I want to give you one more example before I finish, because this review really caused a ruckus in 2010, and they've just updated it. And this is a review from the world of neuro rehab, stretching for contractures. It's a Cochrane review done by actually some of Steve's colleagues. And it really caused a few angry mobs, and certainly people who I work with were furious. We actually now use it with our undergrads. We give them a review and we artificially divide them into two groups. One have to defend the continued use of stretching in neurological patients, and one group have to defend abandoning stretch as an intervention, and they have to do a panel discussion. It's a great way of getting them to engage with the evidence. But this is the evidence for stretching, different types of stretching, short-term effects on range of motion in people with neurological conditions. Stroke, nothing there, yeah? Cerebral palsy, nothing there. Spinal cord injury, nothing there. Acquired brain injury, one very, very small trial, very small trial, okay? So then you might say, well, maybe they're just doing the wrong type of stretching, But, you can think about that. You can start subgrouping down. If you separate out, they showed this graph just to show these studies casted, these studies splinted, which is a very sustained form of stretch, nothing there. These studies did self-administered. There's not much data there, but it's looking a little bit more positive. These studies did use positioning and positioning systems. These studies use other types of sustained passive stretch. So then you can say, well, maybe it's not the type of stretch, but maybe they just didn't stretch enough. Maybe it's the dose of stretch. But they did a meta-regression looking at the impact of stretch dose. And these are all the studies. The size of the blob symbolizes the weight of the study. And they did a regression of basically how much each extra log hour of stretch time in this trial affected the outcome effect estimate. And the mean effect of stretch time for each increase in total, mean effect for each increased hour was 0, with 95 confidence intervals from -1 to 1. And the reason I'm showing you is actually, what an interesting set of data. I mean, it's completely counterintuitive to people in rehab. It's really hard for people to accept. And of course, there are limitations to the studies, and there are still some sources of uncertainty. But you can look at subgroups to look at whether it was a problem with the type. You can look at dose, and with the best available evidence, you would say, it's not looking good for stretch, for contracture. Right? It's not looking good.
So, yeah, but there's a ceiling in terms of how your range of motion, you can't just increase forever. There's a biological range.
There is, but they're stretching these people because they have substantial spasticity problems or contracture problems. And these people aren't getting anywhere near that ceiling of full range of motion. It's not like you've got a healthy population that you're stretching. You've got people that you're stretching because there's a clinical demand for that intervention.
So is it agreed upon that that's the most important outcome variable? Like someone had less pain, but...
No, there's not that agreement. But when we stretch, the main reason for stretching is to lengthen and is to get range of movement back. So for that outcome, they're quite compelling data. But there might be other reasons to stretch. And I haven't gone through the secondary outcomes of the trial, but the primary reason we stretch is to improve range of motion. The primary reason we use resistance training is to improve strength, et cetera, et cetera.
For the sake of Jessica and the recording, can you repeat that question?
The question was, is stretch the only important outcome? And my answer was, possibly not, but the reason that most people stretch is to improve range of motion. They probably included some secondary outcomes, but I haven't looked at them in this instance. So when you're looking at a meta-analysis, what questions might you ask? What have they pulled together? And is that defensible? Do you think that gives you something meaningful? And that's not stats. That's content knowledge really that drives that, right? Is there heterogeneity when you know where to look now, right? The chi-squared, well, visually look at the effect estimates for each of the studies in the forest plot. Look at the chi-squared and the I2 statistic to see whether heterogeneity seems to be a problem. What is the effect size in terms of size and precision? Meta-analysis is a fantastically powerful tool when used correctly, but it is abused, and also you often won't get consensus about when it is truly appropriate to pull things together. You need to take real care in executing and interpret them. You always need to remember that statistical significance is not the same thing as importance. So you need to have an idea of what kind of effect would be meaningful in the context that you're interested in. And if you're interested in reading anything about these, the Cochrane Handbook is really, really detailed. But actually, do you know what? The chapter on risk of bias, which is chapter 8, is an awesome primer for clinicians on how we look at bias in trials. And these 2 old books are still really good. They're still really good. And that's that. So what we've got now is probably a short break. So should we have 10 minutes, 5 minutes? And then you have a systematic review to critique, which is by Weber et al., which I think we've got printed off. And you've got a CASP tool for that as well. So you know the drill by now. We'll have a bit of a break. And then should we say at 3:10, you can get cracking on that?
Yeah.
Awesome.
Translate 3 into typing. I'm like, 3:10. Backwards speaking.
Somebody have a key in their pocket?
It's in the kitchen.
Oh.
So I actually don't know that. I know that 2 things happen. One is that it can't come, but also less functional. So let's say I don't have like 2 or 3 out of 5 strings. We can kind of right? But if it's contracted here, it doesn't have to serve functionally. Where did you make but it is also, I think, comfort. Right. Okay. That's the thing, is you don't have to
So hypermobility is bad.
Is it?